and good evening. So today is our second episode, but I'm going to name it episode 1 since yesterday was the introduction. So this is the Daily Nurse Practitioner, and I'm just going to talk about a short topic in the nurse practitioner world. Today I want to talk about some of the changes in pre-eclampsia guidelines that have happened over the last few years, and what kind of things you should be implementing in your practice as either a family nurse practitioner or women's health nurse practitioner. So and I really learned a lot in creating the content for this video for myself about how frequent preeclampsia is amongst pregnant women. So preeclampsia occurs in about 250,000 pregnancies per year. Around 5 to 7 of these pregnancies are affected, of pregnancies at all in America are affected by this condition. These are great risks both to the baby and the mother throughout pregnancy. The only treatment is delivery of the placenta, but both the mother and infant will then have an increased risk for cardiovascular disease later. So, understanding and finding ways to prevent the condition is the best method since there's no true treatment or cure once a woman has contracted it during pregnancy. So, the current guideline is low dose aspirin, which is an 81 milligram baby aspirin, should be administered daily to those with moderate to high risks. So what do we do as providers? Step 1, we identify patients who are at high risk of developing preeclampsia, and those who are at high risk are those with a history of hypertension or preeclampsia in a previous pregnancy, multifetal gestation, pre-existing conditions such as diabetes, pre-existing hypertension again, certain autoimmune conditions like lupus and kidney disease, and those at moderate risk, so we've got moderate to high risk, those at moderate risk include prima gravida, 10 years since their previous pregnancy, BMI greater than 30, age greater than 35, family history, and IVF. So first we need to identify the patients, then we need to figure out what kind of counseling are we going to provide them alongside the aspirin. So counseling on the importance of adequate prenatal care, including regular blood pressure monitoring, and encouraging a healthy lifestyle with the balanced diet, adequate sleep, and regular physical activity. We want to prescribe low-dose aspirin for those who meet one of the criteria for high risk or 2 of the moderate risk factors, and that's who you're going to prescribe for. So 1 high risk or 2 moderate risk. Prescribe low-dose aspirin for patients starting from 12 weeks. 12 weeks is the best time period to start. If you don't catch that they had preeclampsia or had some sort of a warning sign or they didn't show up until they were 20 weeks pregnant, that's okay. If you start at the latest that you really want to start it up to is 28 weeks. After that, it's not considered a good time to start therapy. And the best outcomes are really if you can get it started by 16 weeks. So start by 12, 16 is ideal, 28 is kind of the end of it where you would want to start that. But you do continue it throughout pregnancy. And if there's any type of contraindications for them taking aspirin, then you would not. But again, you give it until delivery. There's currently no identified risk of placental abruption, peripartum bleeding, congenital malformations, or any adverse fetal or neonatal effects. So we haven't found any, not saying that they won't find something because they're constantly finding issues with medications down the road that we didn't really know about. But for now, low-dose aspirin doesn't seem to have any adverse effects. For those at high risk, utilizing vitamin D6, vitamin D, either 600 up to 2,000 IUs per day has been shown to decrease incidence of preeclampsia. And if someone has low dietary intake of calcium, you want to try diet first. If they're getting less than 1,000 milligrams of calcium per day and can't increase that with foods, then you would supplement with 500 milligrams of calcium. But it's really easy to get enough calcium. Vitamin D, on the other hand, that one is more increasingly routinely prescribed to patients with risk of preeclampsia. Monitor patients closely throughout their pregnancy, including regular blood pressure testing at home. So help them find resources or help them find a low-cost blood pressure machine to take at home, teach them how to take it, and do urine protein checks during visits, though not at home, and consider additional testing such as fetal growth ultrasound. For patients with severe preeclampsia, prompt delivery is usually the recommendation to resolve the issue, and magnesium sulfate should be administered to prevent seizures. That's, again, if you're more of an inpatient provider. For patients, throughout the pregnancy, if the patient remains normotensive, so we never get to the point where we've developed preeclampsia, it means we don't have to start treating them like they have it, right? They don't need serial ultrasounds. They don't need biophysical testing. We don't need to do any of those things that are indicated for patients with preeclampsia. We do treat them as 2 separate populations. So again, normotensive, we don't start doing the protocol things for preeclampsia. If patients do not develop preeclampsia, they can have midwife deliveries. So as long as they stay normotensive, they can start off with a midwife. They again should be put on the aspirin, but they do not need to be under physician or hospital deliveries if they never develop the preeclampsia. They can use intermittent fetal monitoring during delivery. That means they don't have to have the continuous monitor, and standard postpartum vital sign monitoring, standard VS, vital signs every 4 hours, standard monitoring, nothing like that. Though we do need to make sure during and following delivery we are monitoring blood pressure on patients, period, because there's a small number of patients who will develop something called postpartum hypertension. After delivery, patients should continue to receive close follow-up care for those who are at risk or who develop preeclampsia and be monitored for any lingering hypertension or postpartum complications. Routine screening and education are important in this population because there are long-term poor outcomes in those who do actually develop preeclampsia, so we have to continue the monitoring throughout. It is definitely recommended that patients monitor their blood pressure at home for at least 3 weeks following delivery if they're high risk, or develop preeclampsia and notify the provider if their blood pressure is 140/90. We need to call or have a patient come in by the end of the 3 weeks and no later than 12 weeks. And hypertension is known to persist in many patients with preeclampsia, so that's why we need to have those follow-ups. If the patient had developed preeclampsia, we also want to make sure we are getting them an appointment within the first 3 to 6 months to assess their cardiovascular status in general, including either a primary care provider or internal medicine or women's health, or even a cardiologist can be appropriate to monitor a patient or assess a patient who had developed preeclampsia. We need to encourage patients to plan for their future pregnancies and to continue healthy lifestyle habits to reduce their risks of developing preeclampsia in future pregnancies. We just need to keep on monitoring them to ensure that we can keep them normotensive during their pregnancies, between, and keep on going. So that's kind of my update with preeclampsia. There is a ton of new articles that came out in 2021 that detail some of these things more in depth, and I'll link those in the comments or the description. And some of them are done by ACOG. So again, I'll link everything in the description, so you can go and review those articles yourself if you want to. They were very, very long, so I read through the whole thing and picked out the important information for you and put it in kind of a stepwise fashion of how we would approach this patient. So if you like this, please give me a thumbs up and subscribe, and look out for more of these to the Daily NP Show. Bye.